Good morning, everyone. I have changed my order a little bit. First, I will talk about the major clinical trials related to treatment, then go on with the selection criteria. The major clinical trials before anti-VEGFs were cryo-ROP and ET-ROP studies, and after the anti-VEGFs, we have Rainbow, Butterfly, and the others. So let's start with cryo-ROP. In 1988, to assess safety and efficacy of cryotherapy in ROP treatment, it was started in 23 centers based on Japanese evidence from the 70s. There was a definition for threshold drop to the patients which will undergo treatment, stage 3 ROP involving at least 5 contagious or 8 total clock hour sectors of zone 1 or 2 and plus disease. So these patients were given treatment. Cryotherapy was done within 72 hours after randomization, and it was reapplied within 17 days if necessary, and structural outcome was assessed at 3 and 12 months. The adverse outcome was mostly studied: retinal detachment, macular fold, or retrolental mass. Many babies were screened, and nearly 300 of them were randomized. Mean birth weight was 800 grams and gestational age to 26.3 weeks. 80% were symmetrical. Treatment was done at a median of 11 weeks, and there were mean 50 cryo applications per eye. Of course, there were some adverse events during the application. Retinal or vitreous hemorrhage in nearly 20%, conjunctival or subconjunctival hematoma in 10%, conjunctival laceration, proptosis, even under local anesthesia, bradycardia, arrhythmia, and cyanosis were seen. So let's look at the results. At 3 months, cryo group has an adverse outcome around 30%, but the controls were more than 50%. Let's look at month 12. The results were similar with cryo group. Nearly the complications were half, 25%, but controls 47%. At 5.5 years, again, with cryo group, unfavorable structural outcome was 27%, but for controls it was 46% nearly. And they were able to look at the functional visual outcome as well. An unfavorable visual outcome was 47% in cryo group, but nearly 62% in the controls. At 10 years, the structural outcome were similar between the groups. Cryo groups unfavorable 27% and controls 47%. An unfavorable visual acuity, the visual acuity less than 0.1, 44% in cryo group and 62% in control eyes. The ratio of retinal detachment was nearly 20% in cryo group, but 40%, 2 times more, in control eyes. This study has also 15 years of follow-up. In cryo group, unfavorable outcome was 30%, controls 52% nearly, and unfavorable acuity 45% in cryo group and 65% in control eyes. So it was a good option, but not as good as we want. Then come the ET-ROP study, early treatment ROP with laser or cryotherapy. These 2 treatment options were considered, and the treatment was given earlier, within 46 hours. 400 babies were randomized, and mean age at treatment was 35 weeks in early treatment group and 37 weeks in conventional treatment group. There were again systemic adverse events like apnea, bradycardia, arrhythmia, and cyanosis, 2 times more common in the early treatment group as they were more premature at the time. Let's look at the results again. At month 9, with early treatment, there was only 10% structural bad outcome. With conventional, it was 16%. And visual results were also better in the early treatment group. At year 2, again, early treatment was better. And at year 6, Again, early treatment structural outcome was bad in 9%, and with conventional it was 15%. And they were able to look at the visual results as well. When compared to month, it was nearly the same at year 6 if you look at the overall results at 25% with early and 29% with conventional. However, if you divide it according to the ROP type, in type 1, the early treatment was more beneficial, statistically significant. In type 2, it didn't differ that much. Therefore, they concluded that in type 1 patients, zone 1 plus every stage, or zone 1 stage 3, or zone 2 stage 2 or 3 plus should be treated early. But type 2 patients, zone 1 stage 2 or 3 without plus, and zone 2 stage 3 without plus should be followed closely. Then come anti-VEGF. So let's look at the first study, BTROP study, which involved bevacizumab for zone 1 or 2 stage 3 plus bilateral cases. Conventional laser treatment or bevacizumab were applied, and primary outcome was the recurrence of ROP at 54 weeks. 150 babies were enrolled, 67 zone 1 and 83 zone 2, and 75 received laser and 75 received IV bevacizumab. 143 babies reached 40 at the end of the study, and there was 22% recurrence with laser, but only 4% with bevacizumab. And this was especially significant for zone 1 disease. And mean time to recurrence was 6 weeks for laser and 16 weeks for bevacizumab. And what was more important, peripheral retinal vessels continued to develop with bevacizumab. At 2.5 years follow-up, the patients had refractive outcomes, and bevacizumab caused significantly less myopia, especially in zone 1 patients. With laser, it was like 8.44 diopters for zone 1, and for zone 2, like 5 diopters. More than 8 diopters myopia was especially noted with laser in zone 1 disease. Then there was Rainbow study, which involved ranibizumab compared with laser therapy, and it was done in 26 countries. There was laser option, 0.2 milligram ranibizumab and 0.1 milligram ranibizumab. The patients were assessed at 6 months. The primary outcome was no active retinopathy, no unfavorable structural outcome, and or need for a different treatment modality at or before 6 months. So the treatment success with ranibizumab 0.2 milligrams was 80%, 0.1 milligram ranibizumab 75%, and with laser 66%. Unfavorable structural outcome was only one eye with 0.2 milligram ranibizumab, 0.1 milligram ranibizumab it was 5 eyes, and with laser it was 7 eyes. According to these results, European Medical Agency approved ranibizumab for ROP in July 2019. Let's look at the extension study. At 2 years, there was no new structural abnormality, and 5 diopters or more myopia was more in laser group compared to 0.2 milligram ranibizumab, which was the registered dose. There was no difference between growth, with regard to growth, neurodevelopmental scores, or respiratory health among the groups. At 5 years, let's look at, again, high myopia incidence. It's 8% with ranibizumab 0.2 milligrams, 15% with ranibizumab 0.1 milligram, and 24% after laser treatment. And best corrected visual acuity in better seeing eye were similar. Firefly included patients with aflibercept injections. 0.4 milligram aflibercept was compared to laser. at 24 weeks again. Treatment success were similar between aflibercept and laser groups, and rescue treatment was needed less in the aflibercept group, and this caused FDA approval of aflibercept for ROP indication 2 years ago. And 2-year results in Firefly next study, there was no unfavorable structural outcome between the groups, aflibercept or laser, and both groups were able to fix and follow a toy at a similar rate, and high myopia was more in laser group as expected, and there was no relevant differences in growth and neurodevelopmental outcomes. And Firefly next results were presented at EURETINA last year, but they haven't been published yet. Again, the results are similar. And butterfly study is done again for aflibercept. There are laser versus aflibercept, and only 80% needed one injection. And in laser group, 16% eyes were rescued with aflibercept, and in aflibercept group, 12% nearly were rescued with laser. And this is one of our cases with laser. And there are some bevacizumab studies to evaluate whether we can inject less doses for anti-VEGF. So they started with 0.250 milligrams and decreased the dose, and 0.06 25 milligram bevacizumab was the lowest effective dose for ROP. And they are still going and continuing. Let's go to criteria for treatment and selection of treatment methods. Our goals in ROP treatment are to decrease the angiogenic response driven by the avascular retina by cryotherapy, laser photocoagulation, or pharmacologic blockage of VEGF, and surgical intervention is reserved for the cicatricial stages of ROP leading to retinal traction, hemorrhage, or detachment. The treatment criteria depend on the severity of the disease. The decision to start treatment is based on the assessment of an experienced ophthalmologist who will consider factors such as the zone of the eye involved, the stage of ROP, and the presence of high-risk characteristics. Mild cases often resolve on their own without treatment. Babies with stage 1 or 2 ROP without any signs of progression may only require close monitoring. ET-ROP study shifted our treatment from threshold to type 1 ROP. Again, type 1 ROP is zone 1 plus every stage, zone 1 stage 3, or zone 2 stage 2 or 3 plus. In these cases, treatment should begin within 72 hours. As you look at the timeline of ROP treatment, it started with cryo, then come laser, and then come the anti-VEGF. Cryotherapy is done since 1970s. Indications include poor fundus visibility, lack of laser availability, and physicians' unfamiliarity with indirect laser techniques. However, our standard of care is laser photocoagulation. It's done through a dilated pupil. The endpoint is near confluent ablation with burn spaced 1/2 burn with apart from the ora serrata up to the ridge. You see some of our cases. It's done in type 1 ROP within 48 to 72 hours to avascular retina. Let's see another example. After some time, you see the increase in laser scar size. It is non-invasive. It doesn't have a major ocular complication and recurrence rate is low, but it is time-consuming. It needs sedation or general anesthesia, and it causes myopia and visual field constriction. Retreatment may be necessary for skip areas, resistant neovascularization, persistent plus, or persistent avascular retina on FFA. It's irreversible, and it may cause extensive destruction of the peripheral retina, and concomitant reduction in visual fields may be seen. It's laborious, and high level of training is required to administer and monitor the treatment. Anti-VEGFs are generally indicated for zone 1 or posterior zone 2 ROP, A ROP, posterior disease with avascular macula, and if there is no clear view of retina for laser. There may be insufficient pupillary dilation, there may be corneal or lenticular opacity, there may be vitreous haze or hemorrhage, and there may be contraindication for sedation or general anesthesia. It's fast. It can be done under topical anesthesia. Rapid action, time sparing, preserves visual fields and induces less myopia, but it's invasive, and we don't know optimum drug and dose, not yet. Retreatment may be necessary. We see late recurrence at month 10 to 4 to till 2 years. It needs long-term follow-up for PAR, and we don't know long-term systemic adverse events, and still we may need additional laser. So one of our cases with anti-VEGF. Let's look at some guidelines. There is an UK Screening and Treatment of Retinopathy of Prematurity updated 2022 guidelines. AROP or Zone 1 Stage 3 plus ROP treat as soon as possible and within 48 hours. The other type 1 can be treated within 48 to 72 hours. Zone 1 and posterior Zone 2 treatment requiring AROP or ROP in Zone 1 treat with an antivitreal anti-VEGF agent, safe and effective for use in ROP. But if there is an infection, a periocular infection, please do not do anti-VEGF. For posterior zone, including the notch, it is similar to Zone 1 and Zone 2, except in posterior Zone 2. Treatment requiring ROP in Zone 2, treatment with transpupillary laser to produce near-confluent ablation of the entire avascular retina. You can do anti-VEGF as well. Post-treatment review is important to detect and treat adverse event, monitor disease regression, detect disease reactivation, and determine if treatment is necessary. If you have done laser, look for the eye in 5 to 9 days after treatment, and then weekly for signs of regression. You can do laser 2 weeks again later. For anti-VEGF, see the patient later in 1 to 2 days, and then 5 to 7 days after treatment to detect adverse effects of treatment. Following partial or complete disease regression, regular examinations must be done weekly for 4 weeks, 2 weekly for a further 12 weeks, and then 4 weekly for a further 8 weeks. So up till 6 weeks. And then up to 32 weeks in eyes treated for AROP with bevacizumab. If there is disease reactivation, you can do transpupillary laser. So anti-VEGF agents require more intensive follow-up and carry higher rate of further disease reactivation, requiring further retreatment. For anti-VEGF agents differ. This schedule is from Rainbow study. Longer follow-up may be needed following bevacizumab. And vitreoretinal surgery is indicated for peripheral retinal traction. We also have another guideline in Turkey done with Turkish National Society and Neonatal Society and Ophthalmologic Association, and it can be found in the internet. For severe ROP, for stage 2 or 3 ROP in zone 2 with plus disease, stage 1 or 2 ROP in zone 1 with plus disease, and stage 3 ROP in zone 1, and for AROP, you can apply laser photocoagulation or anti-VEGF. If there is hemorrhagic or cloudy vitreous, rigid pupil, and immature retina, anti-VEGF is our first option. The others, stage 4AB, scat reseal, and stage 5 necessitate surgery. And in Turkey, ranibizumab is reimbursed, but we are required to do Avastin first, bevacizumab. And I want to thank you for all for coming to the meeting.